mast cells. Our next speaker is another very good friend and close colleague of mine, Dr. Maitland, who is the medical director of the new EDS Institute at the Medical University of South Carolina. So I've had a lot of personal interaction to learn how she's blazing trails down there as we're doing the same thing at University of Virginia. And Dr. Maitland is a specialist in allergy and immunology. She's one of the good ones, don't worry. Dr. Maitland's work focuses on mast cell activation and complex connective tissue disorders. So she is bridging clinical care and research and making that in great strides. So please join me in welcoming Dr. Maitland.
I actually thinking about they are listening. No, I'm sorry. Well, first of all, I want to thank you, Dr. and also Dr. in the invitation to come. And I think the timing of this meeting, especially following Easter, is very meaningful to me. There was a Nobel Prize winner in the 1950s that felt that science advances one death at a time. And as you can see, there's a lot of things regarding to the diagnosis of a lot of the issues that we're dealing with and talking to today has to die. Not the people, but the thoughts. And I'm hoping to repurpose what mast cells are doing. And I have to feel, and as a person in New Yorker who hates profiling, I think mast cells are being misprofiled. I think they're doing their job. They just don't have any better ideas of how to do their job better. So my talk is entitled, Got MCAS? Maybe. Let's see. There we go. Fabulous, huh?
So forward, reverse, laser, hit this one by mistake, goes blank, head forward again.
Appreciate you. My Southern roots now. Anyway, as you can see, in my opinion, there are three organ systems that can be responsible for an array of issues that a lot of people in this auditorium are dealing with. So you have the connective tissue, and embedded in the connective tissue are elements of the nervous system and elements of the immune system. And up front are the somatosensory nerves that talk directly to the mast cells at all times. The purpose of the epithelium is to let us know we're encountering an environment that may have a danger. That signal goes to the nerves. The nerves then tell the mast cells there's a problem. Mast cells then have receptors to try to figure out what kind of problem is it. These are my disclosures. And what we're going to be talking about, and this looks like the older talk, but we're going to be talking about nerves and mast cells in the connective tissue. We're going to be talking about the different clinical phenotypes and endotypes of mast cell disease. I don't think the question is whether or not your mast cells are activating. The question is, are they activating to help you, or are they activating to harm you? That's the difference here. So it's really important to understand why your mast cells are misbehaving, not whether or not they are activating or not. And then I want to talk about what I think is a growing body of data linking mast cell dysfunction as a secondary issue leading to musculoskeletal hypermobility that we are now calling hypermobile Ehlers-Danlos Syndrome and hypermobile spectrum disorder. So mast cells are old, like really old. They were first identified in the 1860s in tadpoles. They were found in lots of different organisms, chickens, sharks, birds, and mammals. And in the 1870s, a gentleman named Ehrlich, who named the mast cells Madzellen because they thought they used well-fed cells, felt that these cells were found in every part of the human body. So they're literally acting as the guard to every part of your body that's exposed to the environment. And we all have about 70 to 75 square feet of territory, whether we're talking the skin or the linings of the gastrointestinal tract, the respiratory tract, and the urogenital tract that has to deal with incoming at all times. But interestingly enough, it took 100 years for the mast cells to finally get a job. 100 years. And, you know, nothing like a first impression is in the setting of disease. And that's what most allergy immunology colleagues have been taught. If you are having runny noses, if you're having gastrointestinal upset from a food, if you're having a change in mood, such that you have this impending sense of doom, if you're rashing up, everyone assigns it to mast cells, and that's not right. Interestingly enough, this is a modern epidemic. I would have to say that the burden of disease has completely changed in less than 100 years. And just like Dr. Fairweather just mentioned, this is an environmental epigenetic issue. Well, if mast cells have been around upon millennia, why are they such a problem now? And I have to tell you, we've had a huge increase in both immediate and delayed hypersensitivity disorders. Right now, 1 out of 2 Americans, actually, I'm gonna go global, nearly half of the human population is dealing with an immune-mediated disorder. And in this country, when I started in fellowship, anaphylaxis was considered rare, mostly in the hospital with a medication. Now, the latest data shows that 1 out of 50 Americans have been treated for anaphylaxis. 40% of us have nose and sinus issues. And interestingly enough, autoimmune diseases are also on the rise. Nearly over 50 million Americans have autoimmune disease. And interestingly enough, this study in the Journal of Clinical Investigation left out the most common autoimmune disorder. And that actually is autoimmune mast cell disease. You actually develop antibodies against the mast cells that leads to spontaneous urticaria. And what's really concerning about this study is that if you have chronic urticaria, you're at increased risk for all-out morbidity and mortality, period. That's a huge red flag. So this is my kind of like career in medicine. So I up and down I-95 until this past year. Well, actually just further down I-95. So, you know, I grew up in New York where in the 60s, believe it or not, they were still delivering milk in glass cartons to our back door. Clothing was cotton until silk, right? There was no polyester, there was no plastic. The television went off at 12 o'clock. So, and kids were outside until the lights came on, right? That completely changed. But this is what I was taught when I was in fellowship at Brigham and Women's, that if you have reactions, I have to skin test you. Like I'm looking for IgE to mast cells. And I would refer to Dr. Stephen Galley, who's been doing mast cell research for like 30 years. He's like, do you really think all of us have mast cells so we can eat peanuts and die? That makes no sense. So ever since that time, mast cells, and this is what this looked like to Dr. Ehrlich in the 1880s. He took dye that made the Burgermeister's clothes nice blue. He threw it onto connective tissue and mast cells lit up. So he equated that to a Burgermeister's home, right? Where he's living off the land, as opposed to the mast cells are actually trying to help maintain the integrity of the connective tissue. That's this job. But I was taught, kill them. They're the most reviled cells in the body. Their meddling ways cause our skin to itch, eyes to swell, nose to stream. Cells provoke suffocating asthma attacks, kill thousands of people every year. Their villains are responsible for so much suffering that some researchers have proposed eradicating them. Good luck with that. So I'm entitling this the miseducation of an allergy immunology specialist. So when I see people come in with these symptoms, I was taught to allergy test, allergy test, allergy test, and allergy test. Might as well have that coffee cup right on my desk. And what's even more frightening, even though mast cells were identified in the 1800s and NIH came into fruition, they only had 1,000 grants on this growing burden of disease. And 90% of them was on allergen-driven mast cell activation disease. Only 10%. And mind you, prior to the 1950s, the biggest pathogen for humans was parasites. So now you change the environment completely. And now you're trying to tell these mast cells that have been helping your ancestors for millennia upon millennia to learn a new trick. Not gonna happen. So who opened my eyes to my miseducation was this little boy. And his mother wrote this, and I was just formulating the fact that mast cells can misbehave lots of different ways. But she came to me, and this is Sean, and he was down to 6 foods within 4 years of life. He had anaphylaxis, he had asthma exacerbations, he had bone pain, he had fatigue, he had lost his milestones. And so this goes to the early exposures in childhood and how children are much more vulnerable to changes in the environment. And of course, he went to a lot of different doctors and was lucky that the mom wasn't accused of medical child abuse. So this was his odyssey. Everybody said allergy, except for the 10 allergists before me. So the term mast cell activation disease only came into fruition in 2011. Interestingly enough, global consensus too, and if you look at the data there, he has not changed his protocol. And I have to tell you, I looked at that paper, and I actually sent the article into the journal and told them, first of all, 2 of your authors are running mast cell labs with drug intentions, and you didn't declare it. So there's a lot of issues with that paper. Like he's assigned Wolff-Parkinson-White as a mast cell disorder. I'm like, okay, can you pull back a little bit? So this was a paper that actually came out where a lot of the immunologists who were actually defending the fact that mast cell activation disease is a real phenomena. That just tells me your mast cells are misbehaving. It's not telling me why. And so again, multi-organ system, you have to have at least 2 organ systems that are involved. You have to have medications that target one aspect of mast cell action, right? Because we know mast cells are responsible for lots of other things. And then, do you get better with medications that target that aspect? Like histamine is not going to stop you from having disseminated intravascular coagulation, meaning you can have an anaphylactic event and start bleeding and clotting, and you can use antihistamines all day long, and that's not going to interfere with that. So, first criteria. And literally multiple organ systems, and I agree that global consensus 1 is restricted. They have a tendency to focus on rhinitis, asthma, and by the way, we still arguing among ourselves what anaphylaxis is, right? It's still, I know it when I see it. That's the way it is going now. Skin manifestations, gastrointestinal manifestations, but I've had people have suicidal thoughts on when they've had anaphylaxis. Bladder pain syndrome or interstitial cystitis is also considered a mast cell disease. And we know some individuals who have anaphylaxis actually have joint pain. So literally, those mast cells can misbehave in any part of your body. Now, I understand it's difficult to get a tryptase, not trypsin, tryptase. And my hack actually is I give a script to the patient. Like when they go into the emergency department, I have them give the script to the ED physician. And then if the ED physician still has, I'm like, all right, I hear you. You don't know how to manage this test. Can you just get a red top tube? And then I fax the order directly into the lab. So that's how I get around this systems issue. And then the other markers, here's the problem. They're made by neutrophils, they're made by basophils. So are we looking at a basophil issue? Are we looking at a neutrophil issue? Or are we looking at a mast cell issue? And by the way, mast cells are tissue-based. There are very few that are in the blood. So if you really want to understand what's going on, like, are you going to turn somebody away who's having chest pain and their CKs are normal? No, we need to look further. The third criteria, again, is focusing on histamine blockade. And I have to tell you, the latest criteria that came from the American Academy of Asthma, Allergy, and Immunology has now recognized the fact that, same thing for the Cholumskys at VCU, the symptoms of dysautonomia overlap that of mast cell activation syndrome. So with all these symptoms, are we really looking at mast cell dysfunction? Are we looking at nerve dysfunction, or both? And I would argue both. So once you decide that the person has misbehaving mast cells, and to be honest, I use the term mast cell activation disease, so that takes tryptase out of it. Do you have hypersensitivity issues? Let's just stick there. And then the minority of patients, and thank you for showing that paper, I had 980 people come to me saying they had mast cell. So then I got a glass of water, I looked out the window and refocused to listen to the story. And I would have to tell you, 10% of the patients would have a clonal problem. They either have broken mast cells in the form of systemic mastocytosis or hyperalpha-tryptopenia. But the majority of them are mast cells that are having bad orders, whether they developed an autoantibody whether or not they have cervical spine instability, which will cause dysregulation between the adrenergic and the vagus, whether or not they have a different connective tissue disease, such as Marfan's or low EDS, which is a transforming growth factor, beta. And I have to tell you, and I'll talk a little bit later, I've identified at least 4 different immune disorders that present with musculoskeletal hypermobility. Right? So maybe renaming HEDS and HSD, I think is going to be important. So where we are then, in 1989, we identified only 3 receptors that were responsible for causing degranulation events. And that was with IgE receptor, the IgG receptors, the antibody receptors, that cause degranulation. You have complement, which we forget about, and complement is actually older than the mast cells. And if I remember correctly, complement antagonists are actually used in cardiac transplant. Right? We're now up to this. We have identified all these receptors. For instance, the reason why you can't take fluoroquinolones, you're going through the MERG-PXR2 receptor. The reason why women may have problems going in or out of their menses is because they have estrogen and testosterone receptors. You have the opioid receptor. So this is why certain pen medications that you're taking when you're getting surgery may be a problem. Or you're getting lidocaine that diffuses out, so you're not going to have any local analgesic effects. You have communication. As a matter of fact, I've identified 26 people that had idiopathic CD4 lymphocytopenia complaining that they had mast activation syndrome. So my job mostly has been, I know your mast cells are misbehaving. I need to know why they're misbehaving. And this is what's really concerning. They've identified at least 4 autoantibodies against the mast cells or what the mast cells recognize, leading to chronic spontaneous urticaria, which means your mast cells stay on a higher alert. So it doesn't take much like change in temperature, you smelling something in Bed Bath & Beyond for you to have a reaction. And this is what I think is the most important, in that the identification of somatosensory nerves that was put forth by Nobel Prize winners in 2021, the nerves actually have receptors that can detect dust mites. The nerves have receptors that can detect venom. So here you are sleeping in the cave 100 years ago, you get bit, you don't need to wake up and respond. It's the nerves telling the mast cells, hey, I just got bit by, Jumanji spider, and I need to protect myself. And so I'm going to release chemicals like tryptase, actually will protect honey badgers. If anybody's familiar with honey badgers, they have great protection against venom because they have a super cute amount of enzymes that can chew up the venom and deactivate it, right? Great if you're in the safari, not great if you're living on Fifth Avenue. So we break it down. Once you decide your mast cells are misbehaving, do you have a broken set of mast cells? Do you have mast cells following bad orders? Or I don't know, which is idiopathic. And by the way, this is now being tackled because over 500,000 Americans now have meat allergy. And if you don't ask that particular test, you won't see it. So we now know that idiopathic anaphylaxis is actually associated with alpha-gal. This is the story that was mentioned regarding HAT. This was in 2016 in NIH, NIAD, Dean Metcalf, Josh Milner were saying that, you know what, we're seeing a lot of people running around with a higher level of tryptase compared to everybody else. Interestingly enough, nearly 6 to 7% of the Caucasian population have an increased amount of tryptase running around. But all of them that have it don't have symptomatology. So there's a difference between having the gun and then pulling the trigger. My research has identified, and also the work that's being done at MUSC, it's secondary mast cell activation. Mast cells are getting information from quote unquote profiled allergens, or you have an undiagnosed immunodeficiency. You don't have enough antibodies that recognize strep. You don't have enough T cells, and you almost look like you have HIV, but not. You're just not making enough T cells to keep the mast cells in check. Physical stress, such as having a connective tissue issue because you've had POTS since you were 7. Nobody saw it until you're 12, which I can understand why the ACE would be kind of high, because it's normally 3 to 4 years to get a POTS diagnosis. It's 6 to 12 years to get a diagnosis for immune dysregulation. Because again, a lot of my colleagues have been taught, this is what you look at. It's very myopic, and we need to kind of broaden that view. So, and this is a paper I felt sorry for the gentleman that was profiled in this. So he actually had anaphylaxis to venom, which is almost pathognomonic for having systemic mastocytosis. But they went ahead and looked to see if he had anything else. And yes, he actually did have systemic mastocytosis. He also had HAT, and he had alpha-gal meat allergy. Poor guy. So he and he lives down in Arkansas. So when they're barbecuing, he can't be outdoors with his kids when they're playing football. And this is the work that I was just talking about. Over 980 patients. This is a retrospective study. Again, using the term mast cell activation disease. And let me just talk very quickly about the vocabulary surrounding mast cells. Mast cell activation disorder means you have one organ system that's involved. Mast cell activation syndrome means you have at least two organ systems that are involved. You have brain fog and gastrointestinal upset. You have a rash and joint pain. And then I can find tryptase, which is great. But if you have peanut allergy, which is a mast cell disorder, and the tryptase is never elevated in food allergies, does that mean you don't have anaphylaxis or we don't have enough tests? And that's where we are right now. We do not have enough tests to define the different avenues of mast cell activation. This paper, we identified over 19% of the over 900 patients that I saw had evidence of musculoskeletal hypermobility, mast cell activation events, whether it was driven by the nerves or something else, and antibody deficiencies. And 1 out of 1,200 of us has an antibody deficiency. And you don't know until you don't know. So a little intermission. I always like telling a joke. Okay, so let's just move over to EDS. Okay, so it's interesting in honor of Dr. Graham, who we just lost not too long ago. EDS was described, interestingly enough, not by Dr. Ehlers, but not Dr. Danlos, but by a Russian gentleman who I can't pronounce his name, so I'm not even gonna go there. But literally, it was hypermobility and stretchy skin. And then in the 1960s, we had the Beighton score, which interestingly enough, even though your population was described as Hispanic and non-Hispanic, the Beighton score was actually described about how South Asians and Africans of color were much more likely to be hypermobile. So we're completely underrepresented in understanding the dynamics. And if you look at classic allergic disorders, the severity of classic allergic disorders are much higher in patients of color. So there's a huge unmet need there. That being said, for all the other EDS variants, because we're now up to 13 and probably growing, 1 out of 100,000 to 1 out of 1 million for the more rare forms. But the EDS, HSD, depending on who you talk to, 1 out of 500 to 1 out of 1,500. That's an epigenetic phenomenon. And as said before, and it's very frustrating, you're hypermobile and you get the genetic testing. For the most part, to get the diagnosis of EDS and HSD, you can't get any of these other genetic variants were detected. So it's a diagnosis of exclusion. But we do have a clue from one of the EDS variants, and I would argue that periodontal EDS is the first evidence that we have that, a issue in the immune system can cause a global connective tissue issue. So instead of one of the collagen genes or 10xB, it actually is complement. And if you can't find an immunologist that knows about mast cells, you ain't gonna find an immunologist that knows about complement. That's just the way it is. There's only 2 centers that I know of in the country, but interestingly enough, it's definitely getting the attention of the pharmaceutical industries because there's at least 5 medications that are now available going for complement-driven mast cell activation. So just trying to restrain the mast cells when the mast cells are seeing something they think is dangerous, it's like holding a police officer back who sees a crime being committed. They're not gonna stand down if you use antihistamines or leukotriene antagonists, or even cromolyn, which as Mr. Fenner had mentioned, it only goes after degranulation. Mast cells release chemicals lots of different ways. So just to give you an idea what happens with complement-triggered inflammation, in this panel here, see if this works. Hey, intact collagen fibrils, not intact collagen fibrils. This is hypermobile spectrum disorder and hypermobile Ehlers-Danlos syndrome. and complement is responsible for doing that through the mast cell compartment. So my question is secondary mast cell activation disease a way to identify the basis of individuals that have musculoskeletal hypermobility and the consequences of having long-term musculoskeletal hypermobility issues? And the person who was very instrumental in identifying this in the HEDS population, HSD population, is in this room. Dr. Norris, you hanging around here somewhere? There you go. I think this work, when it comes to phenotyping what's going on in the immune system, will give us a better idea of what's going on with the integrity of the connective tissue. So I'm going to argue that this is a barrier effect, that we've had a huge change in the exposures. Our clothing is no longer cotton and silk. Our foods are no longer locally raised and littered with heaven knows what kind of processed dye or food stabilizer or emulsifier. And that's why I would say a lot of patients who are from the US and then they go to Europe, they tolerated a lot of foods there, because guess what Europe has done? Completely banned these foods. So, and by the way, this was mentioned before, I have to argue that mast cells will respond to danger. That is their job. And so we see a lot of serologic negative inflammation, meaning you can have joint pain without ESR and CRP being elevated, because the mast cells are doing their job in the tissue that has not crossed over to the blood. And so how do we look for whether or not somebody has the etiology of immune-mediated musculoskeletal disorders? Do you have multi-organ system involvement? But I'm not just going to pin it on the mast cells. I got to look at the integrity of the connective tissue, and I also have to make sure that your nervous system is balanced. Do you have a mediator rise? I don't necessarily rely on the mediators. I actually go into the tissue just to identify that the first cohort for mast cell activation syndrome was actually a joint effort between allergy, immunology, and gastroenterology. They went into an IBS clinic, which again is like heavily female. They asked these patients, outside of your diarrhea and constipation, do you have rhinitis? Have you been treated for anaphylaxis? Do you have any issues with neuropsychiatric? And interestingly enough, they readily identified 20 people, looked at different mediators as well as the biopsies, and they were able to say, hey, let's get you off the Linzess. Sorry, I don't know the generic name for that right now. Let's put you on to Zantac and Zyrtec, and 100% of the patients showed improvement. But those individuals didn't have other things that are driving the mast cells. So we're going to look for musculoskeletal hypermobility causing, immune dysregulation causing musculoskeletal hypermobility. If you go through the MERG receptor, interestingly enough, for people who get radiology tests, pre-medicating with prednisone will do nothing. These cells, when they see gadolinium, just explode. So the best thing to do is actually prehydrate and pre-medicate 24, 12, and 1 hour before, and I'm happy to talk about this protocol afterwards. If you're having estrogen and androgen issues, I have to tell you, one of the biggest medications that was used prior to the fancy expensive medications for angioedema was danazol, which is really interesting because danazol for the gynecologists is also used for endometriosis. And so and it's very interesting to see individuals who go on to another medication called TXA for short, which is used for bleeding disorders, also does well for angioedema and swelling issues as well. So there's this idea about repurposing old medications to see if it be effective. So, and this is some great work that's coming out of MIT. They took, all right, this is for the basic scientists in here. They took 2 strains of mice, C3H, or we'll just say mice A and mice B. They infected them with the pathogen that causes Lyme disease called Borrelia and just let them go. What was really interesting, all the mice got sick. They got sick differently. So mice A had some joint pain, some gastrointestinal issues, but they're relatively okay. But what was really interesting is the Borrelia wasn't multiplying. It was just growing longer, hijacking the connective tissue, acting as a squatter. So you can throw anti-parasitic agents at those mice all day long. It's not going to help them with their symptoms. What was really interesting in mice B, the females developed musculoskeletal hypermobility. So here's your infections, where you don't have enough of whatever it's needed to contain that pathogen. And that causes chronic activation of the mast cells, releasing these enzymes that Dr. Theoharides, who's my fave too, he calls them meat tenderizers. Really chews up the connective tissue, causing it to be loosey-goosey. And I just wanted to show you, these are the 4 other conditions that have been shown to be affiliated with immune dysregulation causing global musculoskeletal and connective tissue issues. The oldest one, appropriately named Job syndrome. That actually is a variation in STAT3. You have the HAT, hyperalpha-tryptophanemia, where you have a gain of function, which is associated with mast activation disease, musculoskeletal hypermobility, and dysautonomia. You have the periodontal EDS, again, vasculopathy, autonomic dysfunction, and mast cell disease. And interestingly, the last is Lowy Dietz. They all have bad musculoskeletal hypermobility issues. So you being bendy, you're almost like the canary in the coal mine of this society that's been completely transformed in 30 days, in 30 years. So we've had a complete change in our defenses dealing with an environment it doesn't recognize. As I had spoken earlier to someone, it's almost like your immune system is like Captain America coming out of the ice. He doesn't know who to go after, who's bad, who's not. It is a communication with the borders dealing with the environment and the responders. You have a surveillance that's made with the epithelial that is able to release communication to the nerves and the mast cells saying that there's a problem. You have the nerves saying, yes, this is a problem, and I think it's a pathogen, physical trauma, change in temperature. All of those, and by the way, I developed cold-induced urticaria, and I was teasing my daughter. I'm like, you know, I don't understand why I'm having problems with the cold. I walked up and back, uphill in the cold in New York. I never had problems with hives. What happened was when I changed my lifestyle and became a graduate student, and I think a lot of people who were dancers or swimmers or volleyball players, your conditioning changes. That conditioning will actually change the dynamics between the nerves and the mast cells in the connective tissue. So when you think about, a lot of people are able to point to a particular event that caused them to be unwell. You have to look at what was going on with you at that time. Pregnancy, motor vehicle accident, COVID is a big one. So it's an exposure, an environmental exposure that took away what little reserve you had, which my guess is you've been dealing with ever since you were knee-high to a duck. So you had a healthy epithelium with great communication between the epithelium, the somatosensory nerves, and the mast cells. And because our environment so dramatically changed in less than a generation, that which is dealing with exhaust, like if you live within 500 yards of a major highway, you're breathing in those volatile organic compounds that will injure your epithelium in the airways. If you're eating processed foods, you'll injure the mucosal lining. And then detergents, I had one child who had what looked like bad atopic dermatitis. It turns out mom was just soaking the bottles in so much soap, it actually stripped the barrier. And it was how she was cleaning the bottles, not blaming mom. She was trying to do the right thing, but she didn't know that that's something that she shouldn't be doing. So it's what we have done in our environment that's causing us to be so unwell. And it's manifesting with dysautonomia, mast cell activation disease, and modified connective tissue. So ancient threats, good luck going to safari, because right now your immune system is completely confused. These are the offenders right now. It's a complete mismatch between what you've inherited from your ancestors dealing with this modern environment. And there was a major tipping point, I would argue, in the 70s and 80s, when we started seeing such a dramatic change in what we eat, how we spend our time, what we wear, and how we spend our time. The average American in the 1960s maybe spent 60% of their time indoors. Now it's 90 to 92%. We're inside of something that's manufactured. And this is just a graph from several articles showing that the burden of disease, and I think we really need to pay more attention to complement and its interactions with the mast cell compartment to try to help people get better in conjunction with other disciplines. I think physical medicine and rehab needs to be incorporated much more so. And I'm very excited to hear that you have a physical therapist attached to your clinic. We're working on that. Immunology. Unfortunately, I understand, because I remember the conversation I had with your team a few years ago. They wouldn't even count rhinitis as a mast cell disorder. I'm like, where did you go to school? All right. And then literally, once you figure out that your mast cells are misbehaving or your nerves are misbehaving, we need to figure out the different ways that can be happening. And that will then confirm to more tailored, personalized medicine based on what you diagnose. Right now, we are identifying individuals with autoinflammatory syndromes, immunodeficiency syndromes, angioedema, and we're doing robust genetic testing in addition to tissue testing, because guess what? Mast cells are not really in the blood. They're in the tissue doing their job. These are the various masqueraders, but I would also say collaborators to the trifecta of issues that most folks are dealing with. So we're really talking about, do you have an antibody deficiency or not enough T cells, like the Tregs that you're talking about that help keep the mast cells in check? Do you have, autonomic dysfunction? And that just tells me your nerves are misbehaving. Again, doesn't tell me why. Do you have familial, like you have a structural issue with the nerves? Do you have undiagnosed Ehlers-Danlos, because the time to diagnosis for Ehlers-Danlos is what, 2 decades, right? And immunodeficiency, and interestingly enough, the biggest immunodeficiency I have identified is not the antibodies, it's actually mannose binding lectin. And if you want to talk about immunology, this is part of the complement system. And lastly, the danger signals that come from the epithelial barrier. The ones that most people are familiar with in the health professions is Mediterranean fever. But Yao syndrome, or NOD2, actually is probably the more prominent ones. And we actually have targeted medications for this as well. So epithelial barrier doesn't like the world we're living in right now. And we've seen this in a rise in both immediate and delayed hypersensitivity disorders. Yes, it goes through the mast cell, but I would have to argue that the mast cell is, well, it depends on how you see the chicken or the egg. I would argue that it's secondary mast cell activation, but the way you can do it is having a criteria. And by the way, when you mentioned the global consensus one, the 4th criteria wasn't mentioned. They have always leaned into make sure you're not missing any other disorders. And this is where we are right now. We have a neuroimmune decision tree that is awry. In order to help you feel better, we have to go after all 3 legs. You just can't focus on the connective tissue. You just can't focus on the immune system, and you just can't focus on the nervous system. It is a communication that goes on in the body every moment of every hour of every day. We need to get that happening under the roofs of this historical institution here as well as in South Carolina. Because and bless you, because UVA, Brigham didn't want to do this. Stanford didn't want to do this. Columbia didn't want to do this. Mount Sinai didn't want to do this. Mayo, through Dr. Knight and colleagues, but that wasn't the case in the mothership. Understand, it's much easier when you have to do a 3-minute presentation. Most patients have a 3-minute pitch. You're not going to tackle somebody who's been dealing with issues for more than 10 to 20 years. So.
Oh, good. I know there's probably lots of questions, but we have time for just a couple. Yeah. Yeah.
Biomarkers, not looking at blood, looking at what is the advantage for either somebody who is already diagnosed, let's say, supposedly with MCAS, and also some undiagnosed. Getting biomarkers, let's say, from endoscopy or colonoscopy procedure. And the reason why I'm asking is I have a schedule, and the gastroenterologist is using to do the biopsy for mast cell.
So the question is, if this is a tissue diagnosis, how can we better sort out getting the appropriate testing, especially the immunohistology. So I would ask you to come up and see me. I'm happy to give you the paper that's from gastroenterologists from Brigham and Women's, right? And then I would ask if you have an allergy immunology specialist, I gave you that diagnosis, they need to write a letter to that gastroenterologist, because if they don't do the testing, that's actually compromised medical care. So I'm a bit of a New Yorker, I'm sorry. All day long, which also leads me into, so the question is, what is the crosstalk between mast cells and adipose? Which I think, given all the so-called evidence about GLP-1 agonists, I have to tell you, we don't have enough data regarding GLP-1s and mast cell disease. I don't know what microdosing is. I don't know what that means, especially when somebody's had years of issues. We know that the adipose and the mast cells talk to each other all the time, because adipose acts as a major resource for micronutrient support as well. The problem about GLP-1s, especially if you have a connective tissue issue, what if you start compromising your muscular support of the loose ligaments? I've actually had one patient go on GLP-1 and ended up with worse cervical spine instability. So I think everything, again, has to be in context. And so I have a rule of 5 when you go see a new practitioner, and I tell the patients who come see me, please use this with me as well. Do I have an idea about what's going on? And if I don't, Madagascar, smile and wave, get out. 2, what can I give you? Because you've been having these symptoms for quite some time. Because both Dr. Knight and the center here, we both have wait lists, because we're one of the few that are willing to stay on this medical oasis. What can I give you to help you feel better? Whatever I recommend, what are the potential side effects, right? Even if it's exercise or oxygen. I had one patient that was recommended for a PMR to go aquatherapy, but they didn't tell the physical therapist that she had cervical spine issues. So they had her doing planks, which exacerbated her neck pain, right? And then after that, what is the testing that I'm going to get to kind of go after my hypothesis? Because that's what it is. And then when are you going to come back and talk about all of it, right? Forget about Angie's list, right? I think it's really important for you to kind of go in, because if you only have a few minutes, you have to have very focused questions, especially with certain specialists as well.
One last question, sure.
Yeah, is there any, is anybody looking at these things?
Yes. So the question is mast cell dysfunction mast cell activation disease been identified in other connective tissue disorders? Yes. EDS, low EDs, Marfan's, osteogenesis imperfecta. If there's tissue injury, mast cells, their job is to respond to tissue injury. You just hope that they identify it. It's, it's kind of like, calling 911. Well, what's the emergency? You don't want the police pulling out their gun to take the cat out of the tree, right? So it's important that if the mast cell thinks it's venom, when really it's just, a fly flying by, not a tsetse fly in Africa, it just has a local reaction. It shouldn't go systemic. But that's what we're seeing. And I agree that the fight or flight, we're at a higher state of alert. Anxiety is at its highest here in this country. And it really has to pertain to how we live. So, thank you.
Thank you.